If I can introduce Anthony Hill. Now, Anthony doesn't see himself as a complaints body either, and I want him to talk to you about how he does see his role as Health and Disability Commissioner. And we know that doctors don't wake up every morning and DHBs don't operate to harm patients. That's not what they're aiming to do. But sometimes things go wrong and things don't go according to plan, and quite often the Health and Disability Commissioner is called. And Anthony comes to the role with a lot of expertise. You see, he's been in private practice, but he's also been Chief Legal Advisor at the Ministry of Health and Deputy Director General of Health, and he has been Health and Disability Commissioner since July of 2010. So come and talk to us about how you see your role, Anthony.
Well, good afternoon, and thank you, Mai, for that introduction, and congratulations on what I think is a superb contribution to the conversation between citizen and state, and citizen and other organisations. And indeed, I want to talk a little bit about that conversation today. So what I'm going to do today is do three things. I'm going to tell you what I do, why I do it, and what I want. And one of the questions is, what kind of system do we want? So let me turn to what we do. We do resolve. We receive somewhere north of 1,400 complaints a year. We receive well over 3,000 to 5,000 inquiries. Advocacy has 10,000 contacts, converts that into 5,000 events. That's a small town of people who need help having a conversation with the health and disability system. That's a lot of contact. Much is resolved at a low level, and indeed the statute asks us to do that. Sometimes it is not, and the ones you see on the front page are those that are not. But we also learn and we change because we get out of bed in the morning to resolve, to bring healing and resolution and completion sometimes in an unsatisfactory event, but also to strengthen and to change. Why? We want tomorrow to be better. We want the system, we want providers, we want consumers to know that tomorrow we're going to do a little bit better because we're going to learn from what happened today. And we have a watchdog role. With the addition of the Mental Health Commissioner coming to join us in July, we'll be picking up a specific monitoring and advocacy function in relation to mental health and addiction services as well. That fits really nicely with what we do, and we're looking forward to Lynn joining us in a short time. Let me talk to you though about why we do what we do. So look at the Cartwright vision of 20 years ago. Genesis for the Health and Disability Commissioner's Office. And it was about a shift. It was about a system that would encourage better communication, negotiation, mediation, awareness of cultural and family needs, and a shift of focus from a patient to a doctor. And it's about what kind of system do we want. Let's look 20 years on. A brand new idea and a brand new vision. And look, it's about communication. It's about respect. It's about the patient's interest being paramount, and it's about engagement. It's about the same things that we talked about 25 years ago with Judge Cartwright. So we're on a journey here. And so when I think about the code, and when I think about the New Zealand health and disability sectors, and when I think about the cases that come to us, I think about it in this way. And so the summary on that screen represents the code rights that sit at the heart of the conversation, the engagement between the consumer and the provider in this country. I'm going to tell you a story in a minute, and it's about what kind of system do we want? Because when this is working, we're going to see an openness about what happened and what went on. We're going to see an engagement that has people listening to the consumer and to their family, and that will be impacting on the care that is given. We're going to see seamless service. That means you're not going to get lost between floors of a hospital, between a GP and a hospital, between a GP and a pharmacy, between two GPs sitting down the corridor for another, between providers as you transition between rest homes and GPs and hospitals. In the disability sector, it's going to be about ongoing relationships with providers and a connected and responsive system. But culture eats strategy for lunch, as the organisational texts tell us. So let me talk to you about institutional and systemic culture. Let me tell you a story. One of the cases that we produced last year was about a man who lost his leg. It had to be amputated post-op because of post-op complications. This fits into the category of, quote, stories I don't want to tell when I leave this role. Stories I don't want to tell. And this is why. This gentleman entered hospital, bit of a delay till he had his operation. Operation in the event did take place and was successful. Operating surgeon needed to head off for the Easter holidays. Handed over to his registrar. So a senior doc, but not hadn't completed his training programs. But an experienced registrar, an experienced doctor. Should have handed over to another consultant, but we have a gentleman's agreement on the sword. We don't do that if we're confident about the registrar. Turned out, however, that the registrar didn't know as much about the veins in the lower leg as one might have hoped of a senior doctor, and inexplicably missed something that was going on. But something that was going on was really, really clear, because this leg was blue, it was cold, the patient was in pain, nurses recognised that something was wrong and this was not effective. Junior doctors recognised that something was wrong and this treatment wasn't effective, and the family recognised that something was wrong. And you know, all of those people were talking to each other, and they were talking to the senior registrar looking after the patient. The senior registrar, though, was using an instrument that told him he was getting a pulse below the knee, and he was saying, no, we're okay. I think this is okay. Actually, it wasn't okay. The disturbing thing about this story, in addition to the outcome for the patient, was that the consultant who could have intervened was on the ward and within eyesight of those conversations. But nobody said, would you mind having a look at my patient? Nobody said that. Now, why didn't that happen? Culture matters. And here, the institutional culture prevented those folk who knew there to be a problem from reaching for the person who could have solved it. And the patient would have received appropriate care in time, and in this case did not. Sadly, I have other stories, other cases, and I know these folks' names. We're very careful when we speak publicly, and I try never to, even in my head, position these stories by name, because one day, probably in the Privacy Commissioner's presence, I'm going to accidentally say a name out loud. But I know this person, and I know what happened, and I know what it meant to him. These stories matter. I told that story in a room that had 250 people in it about 4 weeks ago. And towards the end of the session, a woman got up and said, I've got a personal question for Mr. Hill. And you know you need to look impassive when you hear that statement, because anything can come when somebody says that. But you know, this elderly woman got up in the presence of 250 people and said, Mr. Hill, I've been a nurse for 50 years, and my husband died because a junior nurse didn't speak up. Now, I've published other cases recently echoing that same theme. Culture is where I'm going. Our understanding of the relationship between consumer and provider, and as Mai's book indicates, between consumer and state, actually, is evolved and matured. We're getting quite sophisticated. As we slide up Maslow's hierarchy, we're reaching self-actualization, but culturally we're not. Culturally, and I mean institutionally, I mean systemically, I mean the way we do things around here, we've got a journey. And I see the margins. We get it right millions of times every year, and I see the margins where we don't. But where we don't, it's because culture failed us, because communication failed us. So that's where I'm going. I'm going to the place where I don't want to tell those stories in 5 years. I want to permit and encourage and facilitate conversations that see change to that dynamic. So when I talk to students, when I talk to senior doctors, when I talk to people in universities, when I talk to people in hospitals, when I talk to consumers, I talk about that conversation that says, ask the questions. It's okay to ask the questions. It's okay to be wrong, because you don't want to be sitting there later thinking, I wish I had. So, that's a summary of the rights in the code. It's a call to a growing sophistication in the conversation, in the way that we engage with providers and with each other. And it's a celebration of the progress that we're making, because we do really well in New Zealand, and it's right that we recognise that. And we can learn and we can do better. And so no, we're not just a complaints agency, we're a complaints agency, yes, and we do some other things to affect change and to facilitate a conversation. And what I love about Mai's book is that it facilitates a conversation. And that's a really powerful thing to do. You know that when your phone goes and Mai's on it, you're about to have a very interesting conversation. And Mai, I think your book is going to facilitate a great many more. Thank you.